Ladies and gentlemen, please give it up and welcome Dr. Anoop Amarnath, Director, Geriatrics, Apollo Hospitals, Bengaluru, for his talk this morning. Dr. Amarnath, over to you.
Good morning, everyone. Respected elders and the dignitaries who have come in to this conference. I welcome you all to the second day of the conference. It's a great pleasure and honor for me to be over here. Taking forward what Dr. Katosh said, that geriatrics needs to be home-based, care at the point of need, as what we call it. And again, quoting him, the younger generation should take the lead. So we'll try to do what he said and we'll follow in his words. It says in the agenda that it would be a distinguished lecture, but what I thought was, instead of lecturing, I agree. I am sure that all of you will agree that actions speak more than words. So what I thought was, we'll demonstrate something which we've actually done in the setting of home-based care. And this is something which, I announced yesterday morning during the inaugural, that tomorrow morning we'll demonstrate to you that for the first time in India, we have managed to set up an intensive care unit at home. So there's been no other center which has done that, and I'm sure you'll all agree that for an elderly person, what I quote myself yesterday, that if you are not able to come to the hospital, we'll ensure that the hospital comes to you. Now, with this background, if you can see on the screen, I welcome Dr. Jagdish. He's the chief intensivist at the hospital. Good morning, Dr. Jagdish. You can hear me? Good morning, Dr. Jagdish. You can hear me?
Yeah, good morning, Dr. Karo.
Okay. So we are beaming live from Apollo Hospitals. And initially, I'll give you a brief background of what we have done over here. That's Dr. Vikram Kamath, a neurologist who's joining us in the background, and we'll have our cardiologist, Dr. Girish, as well, joining in the background. Well, that's Dr. Girish. Dr. Girish, Dr. Jagdish, and Dr. Vikram, welcome virtually to this conference. We have about 200, 300 people over here. And before we begin, I'll just give them a brief background of what we've done. A year ago, we had patient X who came in with an acute cardiac event. And after the cardiac event, Dr. Girish and his team successfully managed to stent patient X and then get his heart to function better. But unfortunately, what happened is, during the downtime, when the heart was not functioning, he suffered a stroke. That's when Dr. Vikram and his team came on board. And of course, Dr. Jagdish, being the intensivist, was the person in charge of setting this, managing his day-to-day care. Eventually, what happened is his cardiac function got better, his kidney function got better, we had issues with his infection which got better. But the stroke issue which patient X had, that was something which was long-standing. So he required, for his breathing, a separate tube in his neck called the tracheostomy, and for the feeding, a separate tube in the stomach called a PEG tube. Now, this went on for quite some time, 3 months, 4 months. Then we thought that, this type of patients being in the hospital for a long time doesn't make sense. They need to go back home. But if they do go home, what is the level of care that they get? It's very clear that if it's in the hospital, you get the best amount of care. But when you go home, it's not just the care, but also the expertise that is required. So we decided to ensure that whatever expertise we had at the hospital, we would transfer it to patient X's home. And the question was, how do we monitor it? So that's where technology comes into the picture. During the course of this deliberations, we'll have a major lecture by Dr. Umapati, CEO, about technology in geriatrics. But this is a living example of what technology can do for the elderly. So we have a setup at home for patient X, wherein you have nurses on 24/7 on call. We have the equipment which you can probably see on your screens on this side, which monitors them. And we have a system which I'll just be demonstrating in a few minutes, wherein in real time, whatever input is given over there in terms of the pulse, blood pressure, temperature, oxygen levels, as soon as it's entered at the house, we get it in real time at the hospital. And that is how we monitor patient X. So let's start off with the background and with the views of the intensive care person. Dr. Jagdish, good morning.
Yeah, good morning.
If we can just move the screen to your left so that I can bring you in focus a little bit more to the left. Yeah, thank you. So if you can just speak to the audience, Dr. Jagdish, about the background of how we set up this intensive care unit at home, and what has your experience been in managing on a day-to-day level. Over to you.
Yeah, thank you, Dr. Good morning, everyone. Yeah, see, regarding Dr. Anoop has told, one of the patients wherein we had to set up the ICU, close to the ICU facilities at home. We have had few such occasions wherein we had to help the family members to have a facilities which would monitor very close to the extent of what we would do otherwise in ICU at their home itself. Basically, it was like a neurologically ill patient and degenerative disorders wherein by the nature of the disease would either remain the same or would continue to progress. So naturally the stay in the hospital would be quite expensive, like sort of financial burden. And at the same time, to send them to the rehab center, the care they would require and the intensive monitoring they would require may not be able to do it at a rehab center. So that was the time where we decided to sort of look into providing sort of ICU care at home itself. So for that, the requirements were like we have to have sort of trained nurses. We would monitor and sort of alarm us for the change in the parameters which we have told them and sort of updated to inform us or alarm us to take action. And the equipments what we had to have were basically the multi-para monitor which would show us the cardiac rhythm, which would show us the oxygen saturation, blood pressure and the respiratory rate, and the oxygen cylinder or the oxygen concentrator which would provide the supplemental oxygen as and when required. And in most of the cases where we had, they were there on the tracheostomy tube, naturally we have had to have this suction apparatus to give lung dilating as well as to maintain the oral hygiene. So then along with that, we of course had to have a nebulizer and care and the PET care, and we would also assist in sort of physiotherapy. So that is how with these equipments and the manpower we were managed to set up the facilities what we would otherwise provide in the ICU as such.
Yeah. Thanks, Dr. Jagdish. At this point of time, I'll just get our neurologist, Dr. Vikram Kamath, because in the elderly, we see a lot of neurological problems, and I'm sure most of you would know of somebody who's had stroke, and who's, I mean, everyone will know what the background is. If somebody, he or she has a stroke, if it's a major one, for all practical purposes, they'll be bed bound, and taking care of them takes a lot of toll on the carers. So from a neurological perspective, we'll just get Dr. Vikram Kamath to comment on how he's been able to manage in terms of taking care of patient X at home. Dr. Vikram, over to you.
Good morning, everybody, and welcome to the Apollo virtual ICU that we have here. Well, just as Dr. Anoop mentioned, our patient X, after suffering a heart attack, was left pretty much disabled neurologically and required full-time care. Basically, the patient was dependent on all activities for the caregiver was responsible for all day-to-day activities. Now, we managed to put up a setup where there would be a nurse round the clock for the patient. Now, there's also a doctor who visits the patient at least once a day to look up all his parameters. And as a neurologist, we expect certain information to come in every day. Simple things like what's the sensorium of the patient in the morning, evening, his ability to communicate and comprehend to what's happening around him, and a certain objective assessment of his movements. Now, what we do is we would train our doctor as well as the nurse as to how to examine the patient and give the feedback every day on how the progress is taking place. In addition to that, with respect to Mr. X, we've also been able to establish a good home-based physiotherapy program for him, where physiatrists as well as a physiotherapist comes into the picture. The physiotherapist visits the patient every day and is able to carry out 1 to 2 hours of physiotherapy, which is probably what is recommended for these patients. On top of that, being in the hospital, the technology allows us to come online anytime and directly visualize the patient. So then in the event of any complication that the nursing staff refers to us, they are able to immediately access online and have a direct visual impression of what's happening with the patient. If there are times when for some reason we are not able to make that connection, we have even something called WhatsApp and all today, where our nurse is trained to take a short video of what's really happening. Sometimes the patient may have abnormal movements. There's a fear if the patient is having a convulsion or a seizure. So we train the nurse to immediately take a short video, and that's sent to us. It's just a matter of 1 to 2 minutes that we receive the video. We are able to see what happens and give that feedback immediately.
Thanks a lot, Dr. Vikram. So that's kind of a brief background of
Thanks,
what we do from the neurological perspective. And finally, we'll get Dr. Girish, the one who actually saved the life in the initial stages. So monitoring a person with cardiac problems at home can be very kind of tricky, because heart is something which will behave abnormally, and it just takes a few seconds for things to go downhill. So we'll just get Dr. Girish to comment on how we have managed to monitor the cardiac perspective at home. Dr. Girish, over to you.
Good morning, Anoop and friends at the conference. I wish you all well. I'm very glad to introduce under direct supervision and idea of Dr. Anoop, we could set up home ICU. It is a beautiful concept and been working well for the last 6 months. This patient, he was brought to emergency with no activity, cardiac activity, and the sensorium was absolutely zero. When the defib was connected, it showed a ventricular fibrillation. So immediately he was defibrillated. Then the ECG showed an inferior wall ST elevation MI. So moved into the cath lab, angioplasty was done. The vitals hemodynamically were stable, but his neurological symptoms did not improve because of the lag period between the VF initiation at his office and reaching here had caused significant hypoxic brain injury. And then it was all left with the neurologist, medical care intensivist, and Dr. Anoop's idea of bringing back a comprehensive, complete life into his system, not just the vitals. So it required constant monitoring of the cardiac issues, especially because he had suffered a myocardial infarction. So the variables that we were monitoring in the ICU, we could monitor at his own place, like the heart rate, the blood pressure, the postural drop in the blood pressures, the rhythm abnormalities. All these had to be monitored constantly because he was an unconscious patient. His heart rate would go up suddenly. We would not know why, because is it an autonomic dysfunction, or is it an arrhythmia, or is it that the patient is not communicating, but his thoughts are causing variation in his rhythm and heart rate. And also this patient required significant rehabilitation, which involved tilt tabling, postural, putting him prone and supine. So there would be variations. So we have to keep a close watch on stability of his neurocardiac autonomic system. And also he had 2 episodes of supraventricular tachycardia when it was constantly monitored by the nurse and the doctor, and a live video feed was given to us whenever there was an abnormal rhythm, and we could identify exactly what is the problem and give intravenous adenosine, and then we had to get him back to the hospital to ablate AVNRT, which is a supraventricular tachycardia related axillary pathway. And we have trained our personnel to identify rhythm abnormalities and treat if required with a ventricular fibrillation or cardioversion. So it's exactly the same care that can be provided at the ICU in the hospital can be transferred back into patient's family if there is a collective of individuals who are driven to be online 24/7 in terms of video conferencing, as well as giving the scientific feedback to the nursing staff as well as the doctor who visits every day. Thank you.
Thanks a lot, Dr. Girish. So what we have basically shown is that with technology, you can have a home-based care on par with what you get at the hospital. The reason why we wanted to demonstrate this is this may be an isolated case. It's taken a Herculean effort for us to establish this, And most importantly, over the course of the last 1 year, the most important thing is that Mr. X is far more stable than what he was in the hospital, because this is his home setting. Now, the reason why we put this up is because if you can manage a level 3 ICU care at home, I'm sure you can manage your day-to-day consultations with your doctor at home itself. So what we'll eventually be looking at from the hospital's perspective is if you're not able to come to the hospital for some reason, you can always have a consultation with the doctor. And such basic kind of care can easily be provided if we are already able to provide a tertiary level of care. Before I come to the audience, I'll we'll skip that one. So I would just like to thank the virtual presence of all the 3 doctors, Dr. Girish, Dr. Jagdish, and Dr. Vikram. A huge thanks to the IT team who are there at the background. They're not coming in the foreground, but without them, I don't think this live feed could have been possible, and I don't think we could have managed this patient without the IT support. So Mr. Joshi, Mr. Vinay, and Mr. Prajit over here, so they are the IT team, they are the backbone behind all these things. So thanks to all of them. Thank you. We'll just go out of this, Dr. Girish. Yeah. So just to summarize, the reason why we brought this up was because of the fact that we clearly know for geriatrics, hospital-based management may be just one part of it, managing the acute care, but the bulk of the work needs to be done at home, as Dr. Katosh rightly pointed out. So if we're able to do the higher level of care, there's no doubt that we can do a simple consultation at home. It would take certain guidelines that we need to follow, and we're still in the process of setting up all those. But eventually, what we promised earlier on, care at your doorstep. So that is what we're aiming to bring eventually. So that kind of brings me to the end of my lecture, and I'll probably take a couple of quick questions from the audience. I would just also like to mention that we have a huge crowd here from Dignity Foundation. They're doing a lot of work in terms of senior citizens and home-based care. So I thank all of them, and they've been very supportive in our endeavor to providing home care support from the hospital. So I'll just take 2 quick questions before I wind up. The gentleman over there, yes please.
And number 2 is it possible for you to demonstrate a case study, what you have done in Bengaluru of a patient where the home, ICU is set up at home?
This is exactly a case study.
No, but in the home, can we see?
At home,
yes, yes.
For reasons of confidentiality, we are not, my initial thought was that we could beam live from patient X's home, but clearly I'm sure all of you will understand that it's the patient confidentiality which is involved. And as doctors, I don't think we can compromise on patient confidentiality. So whatever we are talking about is on a real patient, and since we are not able to beam from the home because of confidentiality reasons, we are beaming it from the hospital. So whatever we discuss, everything is happening at the patient's home. So that's to answer your second question.
But what about the conditions?
Yeah, in order to answer your first question, it is very individualistic of who can have home-based care. The reason why we took this example is because this is the highest level of care that is required. A person who has a tube in the throat, a person who has a tube in the stomach for feeding. So this requires a lot of expertise. So if you're able to do this one at home, it's very easy to take care of an 80, 90-year-old who's just got mobility issues and is bedbound, and all we need to do is monitor their blood parameters and monitor their medication taking. So if we can do level 3, level 2 and level 1 is a piece of cake. So the criteria would be, if it's level 1, that is just a visit, a virtual visit to the patient just for a consultation, or level 2 wherein we just need to give you an injection. So those are a piece of cake. We can do that easily. But for level 3 and ICU level of care, there are certain criteria that need to be met. We need to have 24-hour nurses. There are certain equipment that are required depending on the patient's profile. But if those criteria are met, I think if we can do this, we can do it for any other patient in India.
Okay, then what is the type of cost?
I knew somebody would come up with this question eventually. I was just talking to my doctors over there, and one of you will definitely come up with this question. I think we need to look at the cost factor from an overall perspective. The cost factor for this has been very high, purely because patient X was affordable. But I think depending on the level of care, Say for example, if you have about, if your requirement is just a one-on-one consultation with your doctor, so it would be just about 15% more than the actual consultation fees which you pay to the doctor. So it'll be as simple as that. But if the requirement is higher, wherein if we need to do a 24/7 monitoring and an ICU level of care, obviously the cost will go up. So it's very difficult to kind of, in this forum, to discuss the precise price points. But I think it would suffice to say that it would not be more than what it would be when you yourself had to come to the hospital.
Right.
Okay, I'll just take one more question and then we'll wind up. Dr. Amit?
Sir,
please. Yes, please.
I'm Dr. Rupa Suresh. I'm internist and a geriatrician from PS Medical College. The first thing is, when I really appreciate that you have a great team where they were able to go and deliver the care at home. Costing is definitely an issue in our country, and this sort of care can only be available for those few affordable people in the urban areas. And when you go back to the rural areas, it's practically impossible to have this sort of care given. But my question is, how old was Mr. X?
To answer your first question in terms of affordability of care, if you look at the National Program for Health Care of the Elderly, which is in the 11th 5-year plan, they've budgeted out about 150 crores. One of the salient features of the national program is to set up a teleconferencing center. And if that is done through the government, I think the cost at the point of utilization, that is to the patient, will be next to nil. All they needed to come in at the other end and we would provide them consultation. So as I said, if it comes through the government modality, if it's kind of through the National Program for Healthcare of the Elderly, I don't think cost will be an issue. Just because it's a corporate hospital and we've set it up to one patient, it doesn't mean the cost will remain the same for everybody. So once we have the government backup through the national program, I think the cost will come down. And again, for confidentiality reasons, I don't think I'll be able to let you know either the name, the age, the sex of the patient, but we'll call it patient X.
Yeah, the only reason I asked that question is,
Well, since it's a geriatric conference, there's no doubt that the patient is geriatric. And by definition, we all know what geriatric is.
And was there a discussion with him that this was the way he wanted to live? Because that's very important, because I'm sure a lot of doctors are here, a lot of elderly people are here. How many of us at age 70 plus, I assume, would like to be at home with the tracheostomy and with the PEG tube? And has this been discussed? What are the long-term outcomes? Because this patient is bound to have some sort of infections. Maybe he's not in the hospital, he's not going to get hospital-acquired infections, but having bed sores, recurrent UTI from chronic Foley or otherwise, and aspiration risk and things so on and so forth. So how often do you think you're going to meet the family to sort of bring up this point with them if the children are not in the US?
To answer that final question, I'm extremely proud to say that over the last 1 year, there's been not a single bed sore, not a single infection, not a single aspiration. So that's the quality of home care that is being done. So the reason why we set up this home care is to ensure that, in the hospital we know there'll be cross-infection. But once they go home, and with the quality of nursing that we've done and with the kind of monitoring that we've done over the last 1 year, not a single episode, number one. Number two is in terms of what the patient required. We will have to have a lot of deliberations. I'm sure, eventually during the end of the conference, there would be one session in terms of what the patient would require. But the fundamental question over here is, does patient X have capacity? So if patient X has got capacity or has done advanced directive, then we would need to kind of go in with their views. But unfortunately over here, as you saw the neurologist discussing, patient X came in unconscious. And after with the treatment, I'm sure with the medical background, you'll know his GCS is about 11. So with that, patient X doesn't have capacity to decide what he or she wants. But the whole family, including the kids, the wife, the whole kind of the first circle, this is what they wanted. So when patient X doesn't have capacity, it depends on what the next of kin wants. And once we decide what the next of kin wants, without the backup of the family, I don't think we could have done this. So this is what the family wanted. And unfortunately, since the capacity issue comes in here, we cannot decide what patient X wanted. So I'll probably,
Doctor,
really
if you don't mind, I'll just ask one question. Here, I am Gurudas. Hello,
yeah,
doctor.
go on please.
How many hospitals are having this facility extended? Then second thing, is it insurance linked? And I am from CGHS, that is central government employee. So is it CGHS also linked with this one? I want to know.
To answer very briefly, as of now, ours is the only hospital which is providing the service. And to answer number two, this is not insurance linked as of now. But you know, the whole point of this conference is to ensure that we have some kind of a social security for the elderly and some kind of health security for the elderly. So we'll be deliberating on that in due course. I'm afraid there will be a lot of questions. Amit will have a chat later on. But I think I'll have to close this session because there are a lot of wonderful speakers lined up, and during lunch or during tea we can always have a one-on-one discussion. Thank you so much for being patient and listening to me. Thank you so much.
Thank you, Dr. Amarnath. May I request Dr. Bajaj to kindly honor Dr. Amarnath for that wonderful speech this morning. Dr. Bajaj? Let's give Dr. Amarnath a huge round of applause. Thank you, Dr. Bajaj.